All right, everyone, welcome to Dementia Care Source. This month is the month of May, and that is Better Speech and Hearing Month, which is the month of the speech language pathologist and audiologist. So who else would I want to bring in other than Megan Martin, who is another speech language pathologist. She works with those with dementia, both in evaluation and treatment of speech and language disorders, as well as swallowing disorders. So welcome, Megan.
Hi, Gina. Thank you so much for having me. I'm really excited to get to talk to you about some really interesting stuff this month.
Yes, this is something that whenever we run into each other or get to talk to each other, we're constantly talking about all the time. So I'm excited we're
Definitely.
getting it recorded.
Yeah.
So Megan, what can you tell us about your experience as an SLP and your work with those with dementia?
So I am a speech language pathologist in the medical setting. I have worked at 8 different facilities, mostly acute care and long-term care or skilled nursing facility. I have had the pleasure to work with many patients with dementia at the beginning stages, middle stages, and end of life stage. I really love my patients with dementia because I feel like we can have such an impact on their quality of life, especially near the end, and the ability that we have to educate families who get so much thrown at them and they have so many different opinions and ideas and medical terms, and we can take the time to sit down with them and walk through exactly what's happening with their loved one. And so I've gotten to work with a lot of different scenarios and situations, which I have really enjoyed. In skilled nursing facilities or long-term care, more end of life and what we can do with that, or in the acute care, a lot of acute illnesses where the patient does have dementia and how that dementia impacts the other things that they have going on, as well as immediate turnaround and the healing process for what they're going through at that time. So it's definitely a passion of mine in our field. I love working with patients with dementia. It's so interesting and unique. Every patient is unique.
Yeah. And just like you said, and for our caregivers dealing with caring for someone with dementia, it's never just dementia. It's dementia
Right.
and maybe a stroke. It's dementia and a hip fracture. So I love that you're already starting us off on the foot of this is going to be complicated and dementia is
Right.
messy. But
Yeah,
I agree that
for sure.
SLPs are such a good resource as far as, your physician may have 15 minutes to come in and go out, as of where we can really take the time to sit with you and talk through your options with you.
Exactly.
So, speaking of medicine, of course, we have a quick medical disclaimer. Just that any content we go over tonight, it's not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek your physician or other qualified healthcare professional with any questions you have regarding you or your loved one's medical care. Never disregard professional medical advice or delay seeking medical care because of something we discuss. We don't recommend or endorse any kind of specific tests or procedures or plans of care. We're just seeking to offer general information and personal insight with our experiences and point of view. Okay, so we've already talked about we are both SLPs, with some similar as well as different, our little Venn diagram areas of passion and expertise. So briefly, I want to talk about an SLP's role with dementia. So for some people that are kind of just tuning into Dementia Care Source, and what is an SLP? What is dementia? So Megan, when you see on your caseload, you're going to be doing a dementia evaluation. What does dementia mean to you?
Oh goodness, such a good question. Um, so it's such a broad term, right? Dementia. You can have early on early onset dementia if somebody who's a little bit younger. You can have dementia that hasn't been diagnosed until they're already middle stage. You can have late stage dementia, end of life. The patient's completely nonverbal and hasn't eaten in a while, whether it's because of appetite or just inability, or you can have anything in the middle. So whenever I see dementia, I always go in there with eyes wide open because it's a learning opportunity for me to see, okay, we have this broad term dementia, but how is that presented in this patient and what else is going on with them? Overall, I'm looking for their cognition how much they're going to remember of what I tell them, and how much they understand, if they're able to follow directions, if they are oriented to where they are, um, as well as their function. If most of the patients that are in a long-term care facility with dementia, are being provided care, whereas some patients stay at home, even following the diagnosis of dementia, whether it's with family or still able to live independently. So I want to open my eyes to this patient and this scenario and what their situation is like prior to them coming to see me, um, so I can give the best unique care to them, and not just treat them as a diagnosis, but as an individual.
Yeah, absolutely. I have a whole course, that Dementia 101 course I know we talked about when I made that way back when. And it took, it's like an over hour course long because we talk about what dementia is, what dementia isn't, the types of dementia, the stages of dementia. So I did look up Alzheimer's Association is a very trusted resource. Their definition of dementia is it's a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. And they're a great association, but I was like, that's not enough. I was like, our families need more.
Yeah.
Because, yeah, I mean, I've worked with dementia patients that, they have a diagnosis of dementia, but sometimes they're still driving. They're still
Right.
caregiving for their parents. They may still be working, all the way to the later stages of dementia. So, it's just such a range, and they may have other health problems going on. So, but yes, we can assume that if someone is watching this course, they're probably already invested in what dementia is. But I think it's important for us as SLPs to, like you said, eyes wide open. Dementia can be, as far as us treating, is this person going to remember what I'm telling them about what we need to do or what our plan of care is? Or is there a pretty substantial memory deficit and do we need to involve the caregiver? So, yeah. Oh, dementia. Could talk about it forever. Made a whole website.
There you go.
Now, a term that our listeners might not be as familiar with is dysphagia. So, when you hear the term dysphagia, what does that mean to you?
So the broadest general definition for dysphagia is trouble swallowing. It's so broad, and we could talk about this forever because this is what I do. It's what I do every day, and it's what I love. So dysphagia is any type of difficulty swallowing. It could be you don't have teeth, so you can't chew your food, or you have extremely weak muscles, so you're unable to generate a swallow. So it's very broad, and then we break that down as SLPs into oral or pharyngeal dysphagia. And so again, it's kind of that a broader term, and then we get to go in and see exactly what's going on and diagnose it, and stage it, if it's mild, moderate, or severe, and determine how we can best help that person with their specific dysphagia.
Yeah, I feel like, again, people watching this course are going to know what dementia is and how much it varies, but dysphagia is a new word for most people. So I never come in and I never say, I'm here to do a dysphagia evaluation. I'll say, I'm an SLP, I'm a swallow specialist, I'm here to look at your swallow. And I feel like more than half the time, if the patient's able to talk, they tell me, I don't have any trouble swallowing.
Oh, yes. Oh, yeah.
If we could be paid by them telling us that they don't need us, it would be great. Just
That would be
I've had people say, "Well, I just can't chew," or "It just gets stuck in my throat," or
great. Mhm.
the husband or wife saying, "Well, they cough a lot." Okay, well, have they had pneumonia a lot recently? Yeah, they get pneumonia. Have they lost weight? Yeah. How are they? Are they hydrated? Are they going to the restroom enough? Are they getting repeated UTIs? Well, yeah, they get a lot. Okay, well, don't kick me out just yet. Like, keep me around for a little bit and let's see if I can help you. Because
Exactly.
people just aren't familiar with the swallow or the importance it plays.
Right.
If you're a healthy adult, you may sprain an ankle, you may get tennis elbow, but as far as knowing how your swallow works, if you're young and healthy, it's not something you have to deal with.
Exactly. Yeah. And I think especially in the later stages of dementia, people begin to realize how um, just natural and habitual it is to swallow and to eat. It's such a cornerstone of society. And like, if we are going to be social, if you and I are going to hang out, we're going to go get food, or we're going to go to the bar, or we're going to go get coffee. Like, we're going to do something around food because that's our culture. We eat at least 3 times a day, if not more. And so when you lose that, it's such a significant part of how we view being human. And it's, you don't realize the importance of it until it's gone, I think, in a lot of cases. So
Yeah.
it's a big deal to a lot of people.
Yeah. Even thinking, we just did a video on with an attorney about advanced directives and living wills and things like that. And it's amazing to see how many people, I think myself included, are like, I don't really want to keep living if I can't eat.
Yeah.
And everyone's different, and there can be very good, perfect reasons to get a feeding tube and need alternative means of nutrition. But that's such a part of who I am. Like, I can't imagine not being able to have my cup of coffee and my muffins and my bagels and my breads. And so, there's a lot of people out there that would say, I don't really want to keep living if I can't eat.
Exactly.
So
Yeah.
it's such a big part of not only our culture, but as we were saying earlier, with when we're getting referrals, when we want to start thinking about, okay, is this a swallowing issue? Is malnutrition and dehydration? They're conditions in themselves, but if you don't have your nutrition and hydration, whatever else you have going on is going to be so much worse.
Definitely. Oh yeah.
Going to compound.
Yeah.
And the pneumonia, no one wants to keep going back to the hospital with repeat pneumonia. If you're coughing, if you're having to clear your throat, we call it globus sensation in the medical community, but feeling like something's stuck in your throat. I feel like that's the most common complaint I get.
Yeah.
Is
It is
people,
very common.
oh, it just gets stuck. It gets stuck on the way down, and people get so used to it. Um, but that's not normal. We need to
Right.
check that out if that's going on. Okay, so we've talked about dementia, we've talked about dysphagia. Another new term, maybe for some, is aspiration. Could you talk about aspiration for us?
Of course. So I'm going to use my non-medical terms. So how I explain it to family members and to patients is that in our throat, we have 2 tubes. One of them you see, that's your windpipe, and that leads down to your lungs. Our other one behind that is our esophagus, and that's where our food goes to go down to our stomach. And then in the middle, you have this little flap that'll cover your airway while you swallow to keep it safe while your food goes down. So what aspiration means is that when you swallow, something isn't working right. Something happens in your throat. So instead of going down the esophagus, the food or water comes forward and goes down your windpipe and goes below the top area, down through your vocal cords and into your lungs. And that's what aspiration is. Issues with aspiration, as you mentioned, is that if that food and liquid get into your lungs and it sits there and it builds up and the patient doesn't cough it up and it just sits there, it can cause pneumonia, which can obviously complicate somebody who already has medical difficulties going on. It just makes everybody more sick and worse and harder to recover.
Yeah, and that's something we've a little fish line for the future. We've got a whole episode where we're going to talk about aspiration pneumonia. We know aspiration alone is not enough to cause aspiration pneumonia, and that we all aspirate, but we will have to save that for a future video because we could go on that forever. So yeah, just like you said, aspiration is when food, liquid, saliva, whatever goes down the wrong way. And just that there are so many things that can cause it. What is it? 17 components of the swallow?
Yes.
There's a lot that can go wrong.
Yeah.
And so that's sometimes I think why swallow treatment can take a while. And also why we have so many different swallow exams, which we're going to talk about here in a second. So we talk about aspiration. Oh, we talked about aspiration pneumonia. Something I get all the time is I won't get aspiration pneumonia. I've had the pneumonia shot. Yeah, it's so sweet and it's so cute, but there's
Oh,
kinds of pneumonia.
yes.
So that's the contagious pneumonia. And so just a tidbit of information, the pneumonia shot is not going to protect you from aspiration pneumonia.
No, that happens
Unfortunately,
all inside of your lungs,
that's totally
and no
different.
shot will affect it.
No, we would be out of a job if a shot could fix aspiration pneumonia, unfortunately. I would take it. I
Yeah,
would go do something else, but unfortunately it's a little more complicated than that.
yes.
So we talked about aspiration, and then one more term I want us to go over is diet. So until I was in SLP school, when I heard diet, I thought, oh, low carb or keto or low fat, whatever. But when you hear SLPs talk about diet, what do we mean when we talk about diet?
We are talking about the different texture of the food that we're going to recommend. And I have to be very careful with this with my patients because I have many people look at me and say, I'm not going on a diet. And I'm like, I'm sorry, that's not what I meant. We're just going to bring you food, regular food. This is just going to be a different texture.
Mm-hmm.
So when we say diet, it's not actually trying to get you to lose weight. It's trying to get you to eat.
Yes, I am very guilty of that, and I've had plenty of patients call me out. But yes, if you hear an SLP talk about their diet, it depends on where in the world or even where in the U.S. that you are about what type of diet standard we use. But some common terms are going to be like a puree diet, minced and moist diet, mechanical soft diet, regular diet. And we can also change the texture of liquids. So if you hear us talk about, oh, they're back on thins, thin liquid is just your regular liquid. And then we can also add a thickener to liquid, which changes how our body swallows it, and everyone's different. We can make it nectar thick, honey thick, pudding thick. I think that's all the ones we really use anymore. And the names are changing too. So just we'll talk more about those later, but just so you're familiar with, if Megan and I say the word diet, I'm not talking about keto or anything else. We're talking about the texture of the food. And something I didn't know until I became an SLP was that diets were a physician order. When I go see my grandma in the nursing home and they talk about, you see people with blended up applesauce, mashed potato trays. I didn't really think about it. I just thought like, oh, they don't have teeth, so they blend up their food. And now I know it's a real medical intervention to prevent weight loss or prevent pneumonia or whatever. So just the things you learn when you're so specialized.
Exactly.
Yeah. Okay. So we talked about all of those, and then we're going to get to evaluations. So how do we determine if someone has dysphagia or has a swallow disorder?
That is a great question. So what's going to happen is we're going to come to that person and we are going to do a bedside evaluation first. We're going to talk to the patient, get a history, of course, go through their chart, figure out what's going on with them, what are their complaints. Maybe they've been coughing on their water or choking on the cheeseburger, or they take an hour to eat half of their lunch. There's so many different things that people can complain of. But they have some type of difficulty swallowing. So then we get ordered. So we're going to take our snacks and we're going to walk in with a little buffet of all the different goodies. And we will just see how the patient swallows. So we're going to look and evaluate from a bedside standpoint. We're just going to watch, we're going to feel the swallow, and we're going to watch them chew, how they orally manipulate it. Can they hold it in their mouth? Can they chew it? Can they swallow in an appropriate manner? Does all of this move as it should? And see what's going on at bedside, and then decide from that if we need to go further in the evaluations. So if we see something that we think needs to be looked at from the inside, from an objective standpoint, then we can recommend one of two different evaluations. So most commonly, what I feel like a lot more people have heard of is the modified barium swallow study. So it is an evaluation, much like what we do at bedside with the water and pudding or applesauce and crackers. We do it in the radiology department with a radiologist and a radiology technician there, and we do an x-ray while they swallow. So that shows us from a side view or a front view exactly what's happening inside. So we can watch the liquids and solids go down. We can see how everything moves, and determine from that what exactly is causing the person's issue and difficulty, and then go from there. The other evaluation we can do past that is called the fiber endoscopic evaluation of swallowing. And that's where we take just a tiny little camera and we go up through the nose and drop it over the back of the patient's tongue. And that way we can see, or I'm sorry, above the patient's tongue. But that way we can see exactly what's going on inside. And it gives us kind of that bird's eye view above their vocal cords and their throat, so that we can see them swallow different foods, same kind of foods, water, milk, applesauce, pudding, peaches, cracker, whatever we have the patient eat, so we can see what's happening functionally from the inside, so we can diagnose what's going on and form the best treatment plan from that.
And have you ever heard of a patient that needed all three?
Yeah,
Yeah,
it's possible. It is, because all three evaluations tell you wonderful information.
Mhm.
And so it's not that one size fits all. It's that we, using our clinical judgment as trained SLPs, we see first what's happening at bedside and just watching the patient eat. And then we get to make that clinical judgment of what is going to best help that patient and what can give us the best information to treat the patient in their difficulty in whatever is happening, and get answers for them. If, as we've mentioned earlier, global sensation is when the food gets stuck here or lower, we can see why and how that's happening, from the inside. So we have more specific information and can go further in their treatment from that vantage point.
Yeah, I think the thing that really sold me on being a medical SLP was the instrumentals.
Yeah.
I don't know how it was for you, but it's just so cool to get both the modified barium swallow study and the fees, the video scope. It's just fascinating to see all those structures, and I'm continually impressed on my patients with dementia, how willing they are to participate in that.
Yes.
You get some families, they're like, I don't know if dad will do that. I don't know. But yeah, most people are kind of game for it. And and it depends on where you are in the country, how available modifieds and fees are. Some are more popular in other places. Where I work in Kentucky, both are pretty available, and it's very fortunate that we have that and are able to use. I know some families have been resistant to, and I don't blame them, because I know when their loved ones in the hospital or in a nursing home, it seems like we're always running tests. I know from being a caregiver, it's exhausting. It's like, can you just please leave them alone? They need to sleep, whatever.
Yeah.
But these are such important tests, because again, like, we don't really, everyday people don't know a whole lot about the swallow and know a lot about dysphagia and aspiration. So they may have a hard time understanding on why more testing is needed. Didn't you just watch them eat yesterday? why do you need them again today? But if you ever broke an arm or displaced a hip, it's just kind of no question, we need to take a look at this. It's the same with the swallow.
Exactly.
So we need to take a look at it, not just so we diagnose the right diet textures, but also that I can plan the treatment.
Right.
Exactly. Maybe we find out, oh, there's a lot of residue in their throat, and we need to really work on strengthening. Literally, it might be these 3 muscles in their throat that really need strengthening. And so we see them every day for a few weeks, and we can fix it, and they can go home on a regular diet instead of a puree diet.
Exactly.
So yes, I love instrumentals.
Me too. They are just fantastic.
Mm-hmm. Yeah, I think it gets a lot of people to buy into it as well, to be like, look,
Yeah.
this is what's going on with your swallow. We have this picture of the graham cracker that went the wrong way. And it's
Uh-huh.
very nice.
And the good thing about what we do is that we always have food. So, it's always a little bit more encouraging, well, if you come, if you do this, you're going to get to eat pudding and applesauce and crackers. People are usually pretty willing to participate in our evaluations. So,
Yeah. Heard from many PTs, physical therapists and occupational therapists say like, oh, they won't work with me. I bring them food. They always work with me. I don't know what you guys are doing wrong. So
right. Yes.
speech therapist is pretty great. Okay. So let's say we do the bedside swallow eval, which is where we just stay with them at their bedside, do a chart review, talk to them, talk to the family, see them eat a few things. We decide they need an instrumental assessment. So maybe we do a modified or fees, and we find out that there's a deficit. We find out that it's going down the wrong way. Maybe they're having a lot of trouble chewing their food, whatever, somewhere between the oral phase, pharyngeal phase, esophageal phase, something is going wrong. Of course, our treatment plan will depend on what is going wrong, but just in general, when are patients appropriate for treatment versus when might an SLP say, hey, we really need to consider the whole picture here?
That is a great question. And that is something that is so unique to each patient, especially with dementia. I know we talked about it a little bit before, that each patient is so unique depending on what stage they're in, how they're functioning, and all of that good stuff that we kind of get to figure out through doing these evaluations, working with the patient. We know more of their level and what stage they're at, in order to see how well they would participate with therapy and be a good candidate. So, for a lot of our dementia patients who are in the late stages of dementia, where you're going to see patients are not really able to follow commands, they don't really respond when you ask questions or cue them, they're going to have very limited ability to participate in things like strengthening exercises because they're not going to be able to follow those cues and commands and model. So they're going to have limited ability to participate. Whereas somebody who is more mild to moderate stages are going to be able to really listen to what you have to say, understand it a bit more. And even if they don't remember it in an hour, they're going to be able to do those exercises if we provide them cues and we model it for them. They're going to follow that. So it really depends on the patient. One thing that we always have to consider too as medical professionals is patient buy-in, and if they're going to be willing to work with our treatment plan and participate in what we are recommending. So that's always part of the equation as well, is patient choice.
Yeah, that was a loaded question and you handled it so eloquently. Yes. I feel like that is, again, some family members say, I don't know if dad's going to want to do this with you. Again, we bring snacks,
Yeah.
but there does have to be a willingness from the patient, even if you don't remember, if in the moment, you can stick your tongue between your teeth and swallow with your tongue between your teeth. That's a swallow exercise we teach. If you can do that in the moment, well, then we'll do that in the moment, and you don't have to remember, all these things later. Again, it
Right.
just so much depends on the patient. I think with this too, it's also, I want to throw in about if someone really is in the later stages of dementia. Like I do home health, and it's primarily with dementia patients. So I've had patients where I go in, they're bed bound, they're not really talking, they're not following directions, they're in that last stage on the global deterioration scale, they're just severely impacted from their dementia. So I still think SLPs are very important. I think we have a place. We can do a lot of caregiver education. We can say, I see they're having trouble chewing. Let's try a pudding. Let's try applesauce. Let's try these different textures. or let's make sure they're sitting up really well. Let's make sure we have a light on their food when they're eating to gain attention. There's
Yes.
so many things that we can still help you with, but we just may not be in and available to help for a month because there may not be a whole lot of skill we can rehabilitate. You think of if you have a 105-year-old that falls and breaks a hip, it's still unfortunate, but as far as the progression they can make with physical therapy is going to be limited just because of their age. So same with
Exactly.
dementia. The more advanced it is, we still have a place and we still want to help and be involved. But it may be more just educating the caregiver on things they can do for patient comfort and quality of life.
100%. Totally agree with that. For sure. There is a lot, and that's one of my favorite parts of working with patients with dementia is giving, like, empowering the family members and caregivers as to how they can best help their loved one, and doing all of those strategies you were talking about to help that patient, even if they aren't able to follow commands, to set them up for success, even if we can't provide direct treatment due to their severe due to the severity of their dementia. Um,
Yeah. I've there's even a few SLPs that I know that work for hospice. And I
yeah,
just think that would be so, I mean, it's a challenge, of course, but that would just be such a rewarding, meaningful part of the process to be involved in. So
that would be
I think we both just have such a heart for not ever wanting families to feel hopeless,
for
that
sure.
this is just how it is and I'm alone, and like there's no need to ever feel that way. I mean, SLPs, PTs have a place and OTs have a place, and respiratory always has a place, but speech therapists too, we will be in there till the end to help with whatever is needed. I also wanted to talk about the types of swallowing treatment that there are, as far as there's restoration, adaptation, and compensation. And we've touched with that a little bit already, talking about the stages of dementia. But
Hmm.
do you care to just talk about restoration, adaptation, and compensation?
Yes. So restoration is when we have visualized what's going on, through the instrumentals that we discussed, whether it be through the scope through the nose or through the X-ray of their swallow. And we noted different deficits, such as, perhaps one of the muscles that's weak, then we can work to restore that. So we can do those direct exercises and direct treatment to address that weakness, to bring them back to where they were functioning prior, to whatever they're currently, going through, like if it's an acute illness or something like that. Adaptation is what we can do if somebody loses their ability to chew. Then we can kind of adapt their foods and make it a little bit softer, a little bit easier. In some cases, especially when we're getting near the late stage of dementia, it might be easier for them to swallow thicker liquids, or, liquids by spoon only or straw only or things like that. So we can change how we are providing it, to make it easier for them, depending on a variety of things, but how their swallow is functioning at that moment in time. And then compensatory strategies, there are a lot of things we can do to assist the patient, with different feeding techniques, or, making sure that if we give them a bite of pudding, we then give them, a drink of water in order to keep residue from building up in the throat, and, going really slowly so they have more time to process and swallow and kind of clear that food down appropriately. And just all sorts of other compensatory strategies we can do, cueing them to swallow hard or swallow twice in order to, clear the food through their esophagus so it's not sitting there. Different things like that that we can, in a sense, assign to the patient based on what we have seen and how to improve their swallow function so that they can have as normal of a swallow as possible at that stage.
Yeah, that's it. That's as far as speech therapy treatment in a nutshell, we're working on one of those three things.
Yeah.
Restoration, adaptation, or compensation. So yeah, that's kind of the meat and potatoes of everything. Just to give everyone kind of a teaser of what's coming, we've got a few more episodes planned. We'll be talking more about the types of diet recommendations that we breezed through super super quick earlier. Why we recommend diet modifications, some disadvantages of diet modifications. That one's going to be so fun. Why we modify liquids, what to do if you disagree with diet recommendations from an SLP or an MD. We'll give you kind of some insider tips there. Another episode will talk about avoiding aspiration, the pillars of aspiration, how to avoid aspiration pneumonia, even if you know your loved one's aspirating. There's other things you can do. We'll also be talking about NPO and feeding tubes. So, whenever we start to look at end of life care and quality of life at the end of life, so alternate means of nutrition with the feeding tubes and things like that. And also, one that I'm super excited for you to lead is talking about the helpful tricks of getting people with dementia to eat, as far as the feeding strategies and environmental modifications. And because I feel like these are the things that I'm consistently seeing on the support groups that I'm involved in. So that's always how I want to frame whatever we're going over, is I look and see what people are having issues with, questions that I know I'm getting and that you are getting, and just building the curriculum around the issues that people are already having. We
Right.
need to create new problems. There are people are having enough problems out there.
So
Um,
true.
yeah, so I cannot thank you enough for your time, and we will be seeing you again soon.
Yes, thank you so much, Gina. I really enjoyed it.